Welcome to Medicine Unmasked, the show where we strip away the confusion, the complexity, and the chaos of modern medicine to uncover what actually keeps you healthy. I'm your host, Dr. Isom, holistic physician and partner in navigating a better, simpler healthcare experience. Today, we're diving into a side of healthcare that affects every business, every employee, and every family: the world of health benefits. And to help us unmask the truth, I'm joined by Silvia Aguilar, a health benefits broker who has spent many years with employers helping them provide the best healthcare benefit options for their employees. If you're a business owner, a healthcare leader, a HR leader, an employee, or just someone who's tired of a broken healthcare system, this episode will change the way you see healthcare forever. So let's jump in and unmask what's really going on behind the scenes.
Dr. Isom, thank you so much for inviting me to this conversation. I've been in the industry for over 18 years dealing with employee benefits, and I see the change and the pricing continuously go up. And I know it's getting harder and harder for employees to afford healthcare, so I am so happy here to talk about it today.
I'm excited to have you here too, because I think I'm going to learn a lot, and I think our audience is going to learn a lot. And so we're going to jump right in.
Okay, let's start.
Let's start with the big one, right? So you've been doing this for 18 years. If you had to redesign what business benefits look like, what health employee benefits look like, how would you design that?
Well, first of all, most employers, what they want is a healthy employee, right? We want to make sure that our employees can come to work and have healthy families. So we want to build a health plan that's going to have accessibility to doctors, accessibility to their pharmacies, accessibility to those tests that are needed to keep them healthy. So if I'm building a health plan, I wanted to make sure that the cost of seeing a doctor isn't so high, the cost of my prescriptions aren't so high, and lab tests aren't so high, so that I can keep up with what's going on with me and, part of my family's health also. So the cost of just accessing care is what's really becoming harder and harder. A lot of doctors are seeing 60 to 80 patients a day. They're only given 5 to 7 minutes to see a patient. You really can't really dive into what really is going on with the patient, with that employee. They're just there to kind of like, okay, what hurts? Let me give you something for it. Come and see me back in 2 weeks. So
2 weeks is good.
2 weeks is good. Well, because they need to get
6 months.
Yeah, they need to get back onto the schedule, and sometimes it's 2 weeks, 3 weeks. So for me, it's more access to more doctors, better doctors here in Las Vegas, and then just making it at a price that people can afford.
Yeah.
So that's what I'm looking for. I'm looking for those doctors who are willing to step out of the norm and create plans that people can come see them individually without the healthcare system telling them you only have this many minutes to see them.
Well, we both would like to see that, but would love to see more, direct primary care practices, being able to provide services to businesses large and small. So with that, what do you feel is right now one of the biggest complaints or concerns that employers are having when it comes to, health plans for their employees?
Well, a lot of the complaints they have is, again, access to the doctors. They're purchasing plans and saying, look, I brought you this plan, here's this network. Well, the network isn't so large. So now I only have access to maybe a few doctors here locally. And sometimes if I have a certain condition, I may have to go out of state. And that becomes a problem. So when you don't have enough doctors, that's one of the problems.
Yeah. So what do you feel employers are complaining the most about when it comes to health care benefits for their employees?
Okay. So one of the biggest complaints is the size of the network. So if they want to give their employees a better network, a larger network, the price of the plan just balloons. But if they can just give them a smaller network, the price does go down. But then the employee comes in and says, I can't see my doctor, or I can't see that specialist because they're not even in the network.
Right.
So that's the biggest complaint, is the networks. The networks are too small here in Las Vegas. And then if the employer wants to do a PPO to get a bigger network, it triples the price.
Right. And so again, like the employer's now having to pay, the employee is also having to pay, right. For a limited network, limited availability, limited access.
Right.
Yet people are having to pay.
Right. Either way, if that doctor's not in their network, they're going to pay out of pocket themselves. So they're going to go outside of network, and it's going to double the price.
Which again, I'm here to argue that is the better option. Like I'm going to say, when it comes to actual health, right, the better option is for you to pay versus, again, paying an insurance company, right, to do what? Right, they're not giving you the access, right? They're not giving you better quality by any means, but yet you pay that premium, the employer and the employee, every single month to hold on to a card for a promise of better health that never really actualizes.
Exactly.
Right. So again, I'm a primary care physician. So again, I'm always going to position to say that if we pay for our health care, right, then our actual health care, not our insurance, then we actually get better outcomes individually. Like I can see my provider whenever I want, right? I have unlimited visits. I have 24/7 access via text messaging. I don't have to wait around. Yeah, and that's at a very low cost compared to what you pay in insurance premiums. But given the fact that we don't really have a choice, right? When we have employers who have 50 or more employees, like now they have to do this.
Right. And it not just have to, but they have to be ACA compliant. So if the plan is not ACA compliant, guess what? It's not going to satisfy that mandate that the federal government requires. And the employer is going to be on the hook for penalties and fines.
So you pay even more money.
Even more money. Right. Even though Nevada does not have a true mandate, it's still a federal mandate. And once you hit that 50th employee, then it will come in no matter what. You will be fined for not offering an ACA compliant plan.
And what does that mean to be ACA compliant as an insurance plan? What does that mean?
The plan has to have certain built-in things. Number one is preventative care. So preventative care is one of the main things that every ACA compliant has to have.
And can we break that down, like specifically? Because I think
specifically
it's a joke.
It's like getting an annual physical every year,
which is a joke, and we'll talk about why that's a joke.
Okay, so every ACA compliant has to have that component in it.
Right, that component stated. Right. We don't know what that looks like, but it has to be that component stated. Right? And that comes as a free, right?
Right. It has to be free
to the employer or health plan person.
The second thing is there cannot be a limit to the plan. So that's another thing that was written into the Affordable Care Act, was that before, health plans or health insurance companies could limit it up to, say, $500,000 or $1 million. Now they cannot put a limit on that health care.
Okay.
So if it reaches $1 million, $2 million, $3 million, they're still on the hook for it.
Okay.
And then the third thing is there has to be hospital coverage. Okay. So a lot of plans right now that are out there, the temporary short-term plans, yes, you can see a doctor, but if you go into the hospital, again, you're not covered. So those are not ACA compliant.
Okay.
Yeah, medically essential coverage, which is called a MEC plan, those satisfy just the ACA part, but does not satisfy the hospital part. So it's not a full plan. So the moment you hit that 50th employee, those plans.
So it cannot cover hospital and still be considered ACA?
Yeah, if you have certain amount of employees. It can be one of your plans, but you have to offer the hospital coverage on another component.
Okay.
It has to be a separate component, but somehow or other you have to be able to offer hospital.
Right. So in order to be ACA compliant, you have to have a free preventative exam. We'll talk about why that's funny. You have to cover hospital, and you can't have a limit to what you cover.
Right.
As far as like the financial amount.
Exactly.
Okay. That seems simple enough. What makes it not so simple? Why is it so hard?
Well, because a lot of employers have multiple states, employees in multiple states, businesses in multiple states. The moment you have another employee, say California, that same plan has to meet California requirements. Or if you go to Texas, or if you go to Washington, every state has their requirements. So not all plans will fit those requirements. Not all states will allow you to bring that plan. So again, the network is the biggest thing. You have to have a good enough network that an employee can go anywhere in the US and be seen.
And that's going to cost you.
And that's going to cost you. That's the bigger networks. The bigger the network, the higher the cost.
And I'll ask you, do you see justification for the cost? Like how do we justify that cost?
Well, the fact that what a doctor charges in Las Vegas is so different from what a doctor charges in California, New York, San Francisco, okay? As opposed to a doctor in a rural town in Iowa or Texas. So again, you have to take into account, you don't know where this employee is going to get sick, have an accident, need medical care. And on a plan that's coverages all over the US, they may be in California. And that doctor's cost, that hospital cost will be different than what it is here in Nevada. So it has to kind of like cover all cost.
But all cost of really high ticket items, right? Because we're not talking about bread and butter, primary care type things. So those things aren't costly. They're costly if they go uncontrolled. They're costly if they go undiagnosed. Like that's when cost starts to rise, right?
Correct.
But where real cost to health plans occur would be specialty, hospitalizations, surgeries.
Correct.
Right? And again, like I'm here to argue that if people get good primary care, right, then we have fewer of those things occurring, right? Barring accidents and things we can't control. But things that are within our control, we can improve upon if we had better primary care. Like, again, not 7-minute visits, right? Not see you in 6 months, not
charge you for getting your labs. I've heard doctors charge you just for you to come in and find out what the results were.
So a system based on insurance, right? Because again, what I realized is that I've spent all of these years paying for someone to teach me how to practice insurance-based medicine. Like we are indoctrinated to practice insurance-based medicine. Like, so when we're training and we're told that we can't order this, or we have to, prescribe this isn't because it's medically sound. It's because this is what insurance will do.
Okay.
And so I've paid to train to actually practice medicine that's based on what insurances will and won't do. Not on real healthcare, but based on what insurances will and won't do. I can't order that test because it's not covered. Not because it's not medically sound, because it's not covered. And so we end up in a system that literally from the time you start training as a physician is controlled by what insurances will and won't do. not because it's medically sound. And so when you get out and you're practicing and you need to order labs for your patient, you can't order what's medically sound. It's medically sound for me to know if your cholesterol is more genetically driven, right? It's medically sound for me to test more than your TSH for your thyroid. I also need to do your T4. Or it's medically sound for me to check your insulin along with your A1C because your A1C doesn't tell me enough information. But they're not going to cover that, right? And then because I use insurance and I don't go direct to the lab, the insurance has this contract with not just doctors' offices. They have it with hospitals. They have it with labs. They have it with
pharmacies,
and they have it with imaging, right? And so they have all these different contracts in all these different sectors of medicine. And so for each one, just think about it, the catastrophic cost that goes into having that many middlemen in this global system, right? So we're at like tremendous cost just because we have so many middlemen. So now that you have the lab and the insurance company like interacting with each other, right, on your behalf, extra cost to you. So the lab has to now charge you based on its contract with the insurance company, and it's astronomical. So for me, a CBC may cost $2, right? The lab cost when they bill your insurance for that same CBC is like $200.
Yes.
Right? So whatever we order, the 8 labs we order, right? Just super, super basic labs. 8 labs I ordered, $30 out of my office, right? To the patient, because I ordered directly with the lab. I'm not going through insurance. Patient chooses to use their insurance. The lab bill will say, the lab says, okay, your CBC was $200, your vitamin D was $800, your A1C was $150, whatever it was, right? Out of those 8, you get to a cost of about $2,500. Then you go and they say, here's the discounted price, right? Because you have paid your insurance premiums monthly, this is the contracted price that they have with the lab for you. Now they've been able to reduce this to, let's say, $2,000, right? From $2,500 to $2,000. And now your bill, right, what's left over, so that's the contracted price. Now the insurance company is going to say, that's our contractor discount. We're only going to cover, based on the codes that they put in, based on whatever, we're only going to cover maybe $250 of this. Now you're left with a $250 bill, where if you had just gone from your doctor straight to the lab, you would have paid $30. All because we have insurances involved. And again, like we say, like, what are we paying for? You paid your premium, which is probably, and again, now you're paying again in order to take care of yourself at a bare minimum, right? So what's going to make you want to go back and do that again? Nothing. Like nothing. And even when they say you get a free physical, like being in that industry, being an insurance-based doctor for so long, I know that you can't come in and tell me anything. That's why I think it's a joke.
Yes.
Like I can't discover anything. You're gonna come in, I'm here for my wellness appointment, I'm here for my physical. Great. In order for it to be free, you can't tell me anything. So I can't inquire about anything that's going on with you. We can't deal with hypertension, diabetes, nothing. So how do I then know what to even order for you? Super, super basic. A lot of these companies actually, it's already baked in. Like the doctors aren't even ordering it anymore. That's just how bad it is. It's already baked in. Oh, they're here for their physical. They're only going to get these labs because they know that's what gets covered, and they're not losing money if you were to order something else, right? So no, I'm not going to get an insulin on this person. No, I'm not going to get a thyroid on this person. No, I'm not. I might not get a CBC. So you're getting very minimal preventative care. Like you don't get to discover anything. How do you prevent anything if you can't discover it? So that's why I say it's a joke to me, like that you have to have this free preventative care visit that doesn't prevent anything at all. It gives you some basic information, if that, to do what with.
Right. No,
again, now if you want
that's the complaint I get from the employee, though. See, I get the complaint. It's like, hey, I went to go get my physical, and they still charged me an office visit. And I was like, okay, did you tell them something was going on? Well, they asked me if I did this, or if I, smoked, or if anything hurt. The moment I said, yeah, well, I've got back pain. Well, guess what? It just now became a diagnostic visit. So, yeah, that's one of the employees' biggest complaints when they go back to their employer. Not even the preventative medicine was free because I said the wrong thing or asked the wrong question.
And I think that falls on the physicians, right? And again, those are things that I learned over time, right? When patients would come back and they would complain, same thing. I'm like, we don't know what's going on the insurance end. Like, we're just there to provide care. But when they come back and they tell you like these things are happening, then it allows us to be more diligent about how we put in codes if we care, right? That doesn't always happen, right? So when I know someone's coming in for preventative care, the first thing I say is that in order for this to be free, we can't discuss anything, right? If that's the tone that we take, then I think we all go in with an understanding. So if they decide that they want something addressed, because they don't come to the doctor that often, they don't have that access. Like, why would they waste the time from work or whatever it is to not talk about something?
Well, can I share with you the trend that I'm seeing right now? So when I bring these plans to the employer, more and more employers are going to the high deductible plans. Mm-hmm. What that high deductible plan says, if you need care, the employee has to first meet the deductible before the insurance will come in and cover. Some of these deductibles start at $2,000, $3,000, $6,000.
$5,000.
So it is considered now, in my eyes, catastrophic coverage. Why? Because if I'm going to go see a doctor, it's all my cost. And yet, through insurance, it's still going to be $200 that visit.
What's the difference in those plans then? So like, I can see as an employer, like, why is an employer picking high deductible plan?
Because they're lowering cost. Okay.
Like, how much are they saving by doing that?
They're probably saving a third
of
the cost. And what it does, it puts the burden on the employee to pay, to say, take care of yourself or you're going to pay. Because now you have to shell out the first $6,500, $6,800. So in order for you to do, most employees don't even ever get to that, okay? The most they might have is an urgent care visit. And that might be maybe $2,000 at the most. If your deductible is $2,000, well, you still are in the hook for an additional 20%. So you just to even get to your out-of-pocket max, and those out-of-pocket max are reaching $7,000, $9,000, $10,000.
And so if the employer is paying a third less, how much more is the employee having to pay for those particular plans? Or are they also paying less?
No. They're paying maybe a little less in premium per month, but the entire cost is on them. So $200 to see your doctor. You go to the lab, now you got to figure out what the lab's going to cost you. So it behooves people, and again, a lot of these patients are in my practice, right? They have like these high deductible plans. It makes sense for them to have a concierge or direct primary care provider, right? Because if they really care about taking care of themselves, because that's how they stay healthy. So for, $2,000, or less, or sometimes a little bit more, somewhere in that range, between, $1,000 and let's say $5,000, that's the range you'll find for like concierge or DPC. Like, you can actually have someone that you see as often as you like. Like, we all, have the same 3 basic things, right? Unlimited access, same or next day visits, and 24/7 messaging of some sort. Right, so we all have basic access, right? That you get. So it makes sense for them to then, I would think, right? Yes, if you're gonna have to pay for care, why would you pay for disjointed care?
right? So if you're like, oh, if I need to see the doctor, right? Because now something obviously is wrong because we have a very, reactive healthcare system. So people think I only go to the doctor when I need something, which is bad. So now they need to see the doctor for something. It's going to be a $200 visit, right? Plus labs, plus imaging, right? All out of pocket because they do these one-offs versus like having continuous care if you choose DPC or concierge. And so what if you've seen it at all? Like, why aren't people choosing to do that more? Because my goal is to see almost every physician in a situation where, again, they have more control over the care that they give than having insurances do that for them.
Right. So I think it's the fear. The fear of, if I end up in that hospital for that surgery and the bill is $100,000 and I have no health coverage, at least if I have a basic plan, my out-of-pocket max is $7,000.
So I think that's interesting, right?
Yeah.
So whenever I say DPC or concierge, that doesn't mean you don't have insurance, right?
Right.
The majority of my patients do have insurance, right? They have some type of coverage. They just choose to actually have care because, again, their out-of-pocket deductible may be $5,000. And like you said,
it's going to be more closer to this coming year. It's going to move up to about $8,000.
Right. So now they actually have like care for significantly less than that deductible is going to cost them, where they, again, can see me anytime, message me anytime, and know that they're going to get their needs met. Like, they don't have to be concerned that, oh, I have to go again, it's going to cost me more, or I have to go again, it's going to cost me more. They can see me unlimited number of times without ever having to pay an extra, dollar beyond what they pay on the monthly or their annual premium. Like, to me, they still have insurance, right? If something catastrophic were to happen. So they ended up in the hospital, or they ended up needing a surgery, some freak accident happens. But because these individuals are getting regular routine care, goes well beyond routine, right? They can actually keep up with their health care, right? They can keep up with their meds, or they can get off of meds because they have doctors like me who don't believe in masking things, and we get to the root cause. But my point is, like, these individuals aren't doing ad hoc care, right? Something hurts and we go pay $200 plus $500 plus $700 for labs. Like, again, like, now you spent $1,000 and you had one visit and no follow-up.
Mm-hmm. Exactly.
That gets you just into this bad spiral of having like poor results and poor outcomes. So again, I ask, like, why aren't people choosing to then take it upon themselves to find a DPC doctor? Again, or concierge doctor. Like, DPC doctors are still in town. There's still ones in town that are like $75 a month. Like, just for basic access. Like, this is like working well. Like, our employer plan is $75 a month, right? You don't have to do like all of the holistic care that I provide, but like just basic access gives people better options. Why aren't they choosing to do that in addition to their high deductible plans?
A lot of it is just misconceptions that, if it's not covered under my insurance, I don't know how to use it. I spend a lot of time in educating employees how to use their health plan, and half the time I'm explaining how to get on the app, how to find care, how to utilize it, what questions to ask. You just don't walk into any doctor's office unless they're in your network, or your coverage may not be there. So a lot of it is they just don't have the education on how healthcare works and how you have access to doctors here in town that can provide you that primary care visits. But they want it all wrapped up in a nice little card. They want just the card. Tell me what card I use for dental, what card I use for my doctor, what card I use for vision. That's it. They want the ease of care.
And they would like for it to come from something they're already paying for. Even though that's going to cost them even more.
Correct. Even more.
It doesn't help them be healthier.
Correct.
It's the ease.
It's the ease. I know that Kaiser is looking to come into Nevada. but most people love Kaiser out of California and 5 other states here in the US because the ease of use. You just go to Kaiser. It doesn't matter. Everything's there, all in one building, labs, imaging, doctor.
Right.
People love Kaiser. But then there's people that don't like Kaiser. Why? Because if it's not in that system, you can't go out. If there's some doctor across the US that can save your life because they have a treatment and it's not under Kaiser, guess what? It's all out of your pocket. You have no coverage. So that's HMO, that's managed care.
It is.
So yeah. So that it's just the ease of use. They like Kaiser for the good things and don't like Kaiser because
they are getting better care.
No. And again, Kaiser sees hundreds and thousands of people, but again, they still have the 7-minute visits.
Yeah, it's not better care.
It's not better care.
But it's we've all fallen under, like, people are just too busy, too preoccupied, overworked, overstressed to even consider what it looks like to actually have real care.
Yes.
And so they don't care is what it sounds like. Or they don't know to care. I wouldn't say that they don't care. I don't think they know to care.
I think it isn't that they don't care until the problem comes up.
Right.
It's like you said, we're more reactive than proactive. I'm going to react if I start getting a pain on my side of my side, right? I get a pain in my chest, I'm going to react. But what am I doing to proactively make sure I don't have that pain in my chest?
But here's also where, I've had to realize that, the education that we get as physician fails everybody. Like, the system is bad, right? So you train all these people to provide, again, insurance-based care, which is reactive care. And foolish me, I thought I learned preventative care. I promise you, for the longest, even starting with my own business, I thought I had learned preventative care. So I was very confused when I would hear colleagues talking. I'm just like, what are you, like, they're really sold into this system. And I'm just like, or I hear people say, like, you all don't do anything. You just send us here, you send us there. And I'm like, I paid a lot of money to be able to do a lot of different things. Like, I don't have to send you here and send you there. But the way that we've shaped medicine today, we pay, for a nice size house or a small house if you live in California, right? Your medical school education is going to cost you from anywhere from $250,000 to $500,000 or more, probably growing these days, right? You pay that to get educated here in the US, right? We don't have a country that's paying for us to go to medical school. So you pay to get educated to then do what? Get into an employee system, right? You become an employee in a system now. There are very few people who can practice on their own, especially if you're going to take insurance. Now you're an employee and in a system, spending 7 minutes with the patient, shuttling them in and out, barely being able to get rid of your note, not asking them questions, not caring. So now I've spent $500,000 to send you to this person, that person, this person, that person. Which again gives people less confidence in physicians at all, right? I'm like, slow clap to the insurance companies. They have done a bang up job making us like a non-factor, right? Basically diluting what it means to be a physician, because basically they say anybody can do your job at this point, right? A PA can do your job, an NP can do your job. We don't really need physicians because you're not being paid to think anymore. You're not paid to do procedures, you're not paid to think. You're paid to now just shuttle people where they need to go within that same system, because they don't want to send people outside the system. But like, shuttle these people. Like, I just paid $500,000, but I didn't pay that. Like, it cost me, I think I came out of school with $250 in debt. And now I'm an employee in a system that tells me I can't take a simple mole off a patient. I gotta send this person to dermatology. I can't do a simple IND. I can't take off a toenail. I can't do these simple things. You want me to send this person over to urgent care to get an IND when they showed up to my office. You want me to send this person to dermatology to take off a simple mole. They're here. I'm capable, but now I lose skills that I paid to have. Like, that is the crisis for physicians right now. Like, we are going through this educational system, paying lots of money for you to come out and do the same thing that PAs and NPs can do. right? They don't get additional training, right? You go through years of additional training to come out to be reduced to nothing.
Right. I noticed that I take care of my sister, and she has several medical problems. Half the time she's booked for an appointment, she's not seeing a doctor. She's just seeing an MD.
Our premium is the same.
Yeah, her premium's the same.
Premium didn't change.
Nope. And basically they're just checking to see what is new, what's going on with her, any change in her medication, and then they just reschedule her for another monthly visit. Oh, and it's a monthly visit.
That's good. That's actually better than most, right? Most, it's like, see you in 3 months. Most of the time we're being told, like, you could tell them 3 months, but they can't book that day. When, like, they're going to remember to book in 3 months? Are we going to call them and remind them to book in 3 months? No, like, none of that's happening. And if it's a specialist, it's always 6 months. Follow up in 6 months. Well, you have uncontrolled hypertension. I could be dead in 6 months, right? Just because you gave me medication today doesn't mean that it's going to be working. How do I know? So again, like, we have system, and it happens in primary care too. Primary care may start the medication. You're going to see them in a month or two, 3 months. I'm sorry, 3 months. It's not a month. A month is good, actually, in that world. But 3 months after I just gave someone prescriptions for medications, like, again, no one's winning in this system other than insurance companies, right? So let's talk about some solutions or possible solutions for employers. And like, we've talked about some solutions for like independents, like obviously concierge and DPC, I'm promoting like all the time, all day, every day. But what are solutions for businesses, right? Given that healthcare insurance for them that have to do it is going to go up. I'm assuming those who don't have to do it aren't going to want to do it now.
Right. So for our smaller employers that have less than 50, I suggest that they have wellness incentives. So membership, part of the benefit packages that I've developed have been gym memberships. I had one small employer with 40 employees actually integrate a kayak service, learning how to kayak, because their office is right where next to a kayaking kind of rental. So we went and developed a benefit for the employees, for all 40 employees to go take kayak lessons to keep their health.
That doesn't keep their health?
Well, it keeps them moving and keeps them hopefully excising. That in the long run.
About that too. That's
giving them activities to
gives them activity, but it gives them
activity. A lot of employers have put in basketball courts, volleyball courts, walking trails in their facilities. A couple of employers have worked on the snacks coming into their facility, like no trans fats, healthier waters, healthier drinks. So they are caring about the employee, because I see the change. I see that, hey.
So they're doing alternative wellness activities, but they're not addressing health.
Well, no, a lot of them too will lower their cost of insurance if they do certain activities within the health plan, like get a physical, get a colonoscopy, get a vision check, a dental check, things like that. So if they perform certain activities within that health plan, then the employer is willing to reduce the cost of the plan. So that's one thing. Some employers are doing that. Some employers will, actually the bigger employers, the bigger companies that I'm seeing, will actually put a clinic on their facilities, so that the employee can just get out of work, go straight to the clinic, check up, see what's going on. So I've seen clinics and dental clinics, mobile dental clinics pop up in the employer's facilities.
So going again, so part of my route to here, I was the physician for Coshada Casino, right? So they had an employee clinic on site, right? And then when I first moved to Vegas, I was the first physician to open up the IBEW union's offsite clinic, right? Their first one. was through Activate. So they have these companies, and I've worked for 2 of them, right? That these companies are going in to mainly self-funded, self-funded like unions and businesses, to help them save costs, right? So the businesses will say, okay, we're going to set up our own clinic. They don't know anything about clinics, so they hire these companies to come in and set these clinics up for them, right? So these self-funded clinics. And again, the idea is exactly that. We're going to save money by being able to control costs, right? It doesn't cost a lot for primary care. Like I've sat through all of these minutes. I've been on 2 different companies that did this. And so it does, primary care is not what's increasing the cost of health care in general, right? And when they dive down in their books, it really is the biggest costs are people going to the emergency room when they don't have an emergency, people going to urgent care when they don't have, because they don't have access, right? That amount generally was outweighing any surgeries that were occurring, right? And so by being able to put an on-site, off-site clinic where they can go for free, right, reduces the cost for the business significantly. So they can pay these companies millions of dollars to actually do it because they've reduced their healthcare costs. Again, we're talking about larger companies, like larger plans.
Anything above 500 employees.
Yeah.
It behooves them to look into creating some kind of primary care on-site.
Yes. Right, for that particular reason. So it goes back to primary care is not expensive, right? Access is really important, right? Larger companies are able to do it. I'm trying to understand like how businesses, even smaller, don't understand the relevance and the importance of actually having access, right? And so again, maybe it's just because we're all individual providers, right? Doing our own thing, not necessarily paying attention to these smaller companies. Some of us do try to attract smaller companies for that particular reason. But is it just a lack of knowledge? Because I think it's crazy, right, to say, I'd rather offer you kayak lessons than have you have a primary doctor that you can see at any time, right? For probably less than what it costs you to do the lessons, right? We're talking about, again, don't include spouses or make the employee, but again, most of those plans are somewhere around $75 per employee per month, not per paycheck. So we're talking about $37.50 per paycheck, right? So $75 per month to actually have 24/7 access, no additional copays. Like, why is that not the option? Why is it the way to keep the way to keep a employee happy is to give them kayak lessons? Like, I am floored right now.
No, it's education. It's educating employers and employees the relevance of the fact that access is available. And I think in the last 5 years since COVID, I've seen more and more doctors become concierge doctors.
Yeah.
And so I don't think 5 years ago we had access to that kind of care. So it's going to take time to educate. And I always try to educate my employees when I'm even just with the high deductible plans. Well, okay, so you know that the amount of money you're going to have to pay to see that doctor, you're going to have to shop around and call different doctors to find out which one is less expensive. And that's time on taken out of your day. So be a consumer, be a smarter consumer, and shop around to see what that lab is going to cost you from one lab to another.
Why not just go to DPC? Why are we going to insurance-based doctors that are going to charge you an astronomical amount?
It's education. It's all about educating the employee what's available. So like I said, 5 years ago, maybe you were one of the fewest. I could maybe put primary care doctors in one hand. Now there's way more. So hopefully that will grow and we can start to change that. But for right now, we need more. We need more physicians We need more primary care physicians where they don't have to take that, they can take that high deductible plan and still afford to pay a concierge doctor.
Right. Which again is the trend that I'm seeing for the most part. Like I can say probably the majority of my patients who do have insurance have high deductible plans.
Yeah.
Right. And even when it comes to labs, like, so here's the thing that we see with my practice. They have high deductible plans, right? Some of them are, we can use their HSA to pay for their whole year or what have you. Or we can pay for other things like, other lab tests or whatever it may be, like through their HSA. Or we can provide them a super bill, right? And it helps. So even though they're still having to pay, right? Because we don't bill insurances, it doesn't hit their deductible, right? And so providing them super bills, right, will at least now help them meet that deductible price, even though they're paying out of their pocket. So they don't want to I tell them, you don't want to just pay out of pocket and not at least try to put a dent in your deductible, right? By getting a super bill, you're able to at least, even though you're still having to pay, at least it goes towards your deductible. Because what happens we'll have labs or imaging that they need to do. Now, if we bill it through their insurance, that brain MRI that we needed to get is going to be $2,500, right? Because it's being billed through insurance. So that amount is then left on the patient versus like if we just pay the lab, if we pay the radiology department directly, it's $300.
Again.
And so they're choosing to not use their insurance, right? Because it's going to cost more. So now they have this high deductible plan that they're not even using.
Correct.
Right? Again, because everything they do, they're paying for, and every little bit that they do pay, none of that is going to be going towards their deductible. Because if they try to use their plan, it costs them way more.
Right. Because if the moment they go out of network, it won't be credited to their deductible.
And patients are choosing to pay $300 versus $2,000, right? Because it's something that they need for their health. It's kind of like you're stuck in a hard place because you. What are you? It's $200 for an imaging that you need, or it's $2,000 for the imaging that you need. So do I pay the $2,000 just so I can like hit my deductible, help towards my deductible, or do I pay the $200 so I can keep taking care of myself? Right? So that's the difference between, like, that's what we're seeing now. So they have these plans, they're still paying, right? It costs them a little bit less, but now they have more room to actually take care of themselves, right? It's not they don't care anymore, at least my patients don't, about meeting their deductibles. They know that they can spend less than that deductible and have the best care of their life, right? Including their labs, including their imaging, right? If they went and used their insurance, they would probably pause on having to do the things that they needed to do to take care of themselves. What if you needed to repeat that MRI? That's another $2,000. You're not going to do that, but you'll pay another $300 to do it, or $200, right? And so I see what you're saying. It's education, because again, like, no one would know that it really doesn't cost you as much to take care of yourself, right? And have like the best care ever, versus like, oh, I need to try to meet my deductible. Like, they've tried that in the beginning when they realized it doesn't make any financial sense. Like, yeah, I need it for something catastrophic, and if something bad happens, I got it. Which now brings me to, just had a patient tell me, they now have insurance on your insurance. Like, you can get a rider or an insurance to pay your deductible. So people don't have the $5,000 right up. This is what I heard. I just
well, that's your volunteer. That's going to be your supplemental plans there. Hospital plans that say, you know what, if you land in the hospital, we're going to pay you X amount. That helps you pay your deductible. Basically covers your deductible. So you got insurance just to cover deductibles. Yes. Right? Or maybe a critical illness plan. You get diagnosed with something severe, you get paid out anywhere from $5,000 to $50,000, $75,000. That money can go towards paying your deductible. So it's insurance on top of insurance. Yes.
Yeah, I just heard about that. I'm like, what are we doing? I'm like, no, I want to say I'm in the wrong business, but I'm not. I couldn't do that with a good conscience. So basically.
It's planning for what ifs. It's the what ifs.
It's fear.
Yeah, it's fear.
Right? It's fear, and that fear leads us to be a sicker country. Right? It's not improving outcomes by any means. Right? Your inability to go see someone on a regular basis because it's going to cost you a copay, or because you have to get inconvenienced because you have to like leave work or take off of school or whatever it is in order just to be seen. Like, so going back to that preventative appointment that's free, say you do everything right, it's free. You walk away, they've drawn, a few labs that, mean a little bit of something, but not everything. Now that those labs are drawn, how do you get your results?
You have to make another appointment.
Which means you have to then do what?
Pay your copay. Yeah.
So this is why I say it's ridiculous to call it a free.
Right.
Like, it's ridiculous, right? In order for them to say it's nothing. So most people aren't going to do that, right? They figure if it was bad, they'll let me know.
Correct.
Right? And the physician on the end doesn't know one person from the next because they see so many people a day. They don't always go and review their own labs. Like, sometimes it's been done by like the mid-levels, like your PAs or your MPs. I didn't do all my tasks. Like, I didn't know when people's results were back. Like, again, my thing was like, make sure that they get their results. I don't necessarily have to review them, right? As long as and if they have questions, then they can like that's how it was going. Like, it wasn't like I do now where like there's no one who gets labs done, like whether they're normal or not, where we don't review them. Right? So that you don't know exactly what's going on, right? You know exactly what was drawn. You know how it matters to your health, right? Normal or not. And it doesn't cost you time or money to do it, right? You can do it virtually. You don't have to drive all the way back down here to come into the office for me to tell you everything looks good or we can work on this. Nothing bad, but hey, your cholesterol's going up, or I see your thyroid level, whatever it is that we can do to like get things to start moving back the right way before things get bad. Like, I don't have to bring you into my office to do that, right? You're not having to pay me more money to do that. It still is hard for me to understand how people are still willing to wait for something to go wrong before they actually like decide to get with a practice or a doctor who can actually care for them the right way.
Yep.
I'm speechless. Like, again, this is like the thing that I'm passionate about. Like, this is the thing that I care about. And it's like, how do you get people to see medicine differently? Which I think it's hard because, again, like, insurance companies have done a really, really, really great job at making people believe that doctors are worthless, number one. And because all we're good for is sending you out, which means more money and more time. Who wants to do that, right? So essentially they've made us all providers, right? Like, you don't say my doctor because, again, like you said, you can go and you may not see an actual doctor. You may see a nurse practitioner. You may see a PA. And we'll go back to, but you're still paying the same premium. To see someone who doesn't have the same amount of training. Right. Somebody
that maybe the doctor will review the notes.
No, they won't.
Right. Yeah.
Not at all. Nurse practitioners can practice independently here in Nevada. There's no need for me to ever have to renew. And again, we automatically put in a blurb, like, no one gets, if I'm seeing 20 to 30 people a day and my PA or my nurse practitioner is saying, 20 people a day, whose notes are getting reviewed? There's just
not enough time in the day.
No, and so everybody's burned out.
Unless something really jumps out at you.
Unless it's something they really can't handle. And what I've seen most of the time is that people get mismanaged because they don't get managed well. It's not like, it's like, oh, this person has high blood pressure and their blood pressure is like 160/100, and you start them off on just hydrochlorothiazide. Like, I'm not sure what you expect that to do, but I've given you something for your blood pressure, even though it's going to be highly ineffective, right? That's coming from someone who doesn't have enough experience, right? Or who is too afraid to actually be more aggressive, right? And so it's not that they are mismanaged because you did get a blood pressure medication, so they're not well managed, right? And then they may not see this person for months and not know anything about how their blood pressure has changed over the next couple of weeks, right? And it's fine if they would get follow-up in a couple of weeks. Fine, I'm not that comfortable. I'm gonna give hydrochlorothiazide. Let me know what your blood pressures are in 2 weeks. That's just not what's happening, right? So again, mid-levels, can provide care, but it still isn't gonna be like what a physician is going to be able to do or feel comfortable doing because they have more training. Your MP, and then we have some really great MPs and PAs, don't get me wrong, but that comes from years of experience, right? They can be better than some of the new physicians coming right out of residency just because they've had years of experience, right? And that's basically what it takes. The more years of experience you've had, that's why we have residency, and they don't. Like, you come out generally having more experience, right, than someone who just came out of MP school or PA school. Because they come out of school, they don't have a residency program. They don't get further training. Theirs is on the job. And when you're telling somebody now, I'm gonna pay the same monthly amount, right, to see them whenever, because I don't see them every month. Because if I have to go see them, I have to pay a copay.
Right.
So something really needs to be wrong for me to go see them, to have a copay, for them to tell me to go see somebody else. I'm frustrated with the system. Like, again, like, what other solutions, so we're talking about solutions for small businesses, right? Benefits, right? They don't offer insurance. They want to offer benefits. I argue they should offer health benefits, right? Through a DSP or not DSP, a DPC or a concierge doctor, right? Who has an employer plan, where again, the costs aren't going to be astronomical, right? Because we're talking about the working well who just need access, right? You talked earlier about health shares. Like, how does that fit in for people? Like,
so your health share companies are basically only willing to take you on if you do not have pre-existing. Mm-hmm. So that's a big problem there, because a lot of people get onto a health share thinking that, oh, well, I had a mild stroke, a couple of years ago, and I'm pretty fine now. But, if you had a pre-existing already, that insurance may not cover you for that second stroke, if you do have a second stroke. Or I had a bad knee, I tore my ACL, and all of a sudden it goes out again because there was a pre-existing. It may not cover that second surgery. Right. So health shares are there, but they have to go through a waiting period of almost a year before the health share will pick up any kind of diagnosis or treatment for anything that you were already seen for. Right. So again, you're kind of rolling the dice that you're not going to have a bad year. Anything new
for that,
yeah.
For that pre-existing condition.
But again, health shares do require a deductible, and their whole thing is, I have a local one here that's a $3,000 deductible. You go into the hospital once, your deductible is $3,000. They have a limit that they'll cover up to $250,000. So as long as you're not going over that amount, they're there to cover the rest.
So $3,000 out of pocket for a hospital stay, and then up to $250,000. So then after that, then
again, you go second hospital stay within that year, it's another $3,000. Their out of pocket max is $9,000.
Got it. So like going into hospital 3 times.
Right.
Out of pocket. And so is that up to $250,000 per occurrence?
No, total.
So all 3 hospital visits can't be more than $250,000.
Correct.
Got it. Right. And so you have a major anything that's so again, we don't know about accidents, and again,
you don't know what kind of care that person might need.
No.
Emergency surgeries, anything.
And that's where your major costs are. And so,
but those plans are running anywhere from $150 a month to about $250 depending on age. Okay. So you're priced based on your age.
Okay.
The older you are, the higher the cost.
So pretty much the younger you are working well, barring any like major catastrophic events on multiple occasions, it's an option.
Right. It's $150 a month. You have care.
So for primary care, I know people who have, if you have a concierge or direct primary care physician, you typically get discounts with those type of plans. And so again, they're paying, in order to get the discount, they're already paying a concierge or direct primary care, right? And then they're paying a lower monthly premium.
Right.
But
I think an ideal plan, as you're describing it, having the hospital plan with these cost shares at $150 and then having a primary care for $75, that's way below what a normal health plan costs. So that might be a solution coming your way.
Solution. Well, the practice is way, like as we, bring in more new physicians, right? Because again, that's the goal of Isom MD in general, is to get physicians to have a better quality of life. Because again, being able to care for people the way you were trained to do it, and actually better than you were trained to do it, gives us a workforce of physicians that are going to be happier doing what they're doing, and realizing that primary care is, again, at the forefront of like keeping healthcare like costs down. So again, we have a couple of residency programs here, and I'm partial to family medicine, where again, we can literally just take these young kids out without having to ever go into this insurance-based world, right? But it really is making sure that they have patients to care for. And when people don't really understand the value in actually having access that way, right? It's a harder, I don't want to call it a sell, but it's a harder hill to climb, right? To get people to understand like what that looks like, because we're so used to this reactive care, and we're so used to saying like, well, what are they going to do for me? Like, they're just going to send me someplace else. Like, no, like they're ready to actually continue to
care for you. Yeah.
In the way that they were just trained to. The last thing that they want to do is go into an employed situation and not be able to use any of their skills anymore. All right. So again, hoping the tides start to turn, I agree, in the next few years, where again, we're taking more of these, introducing it to physicians early, right? While they're in residency, saying like, you can actually come out and have better quality of life, right? You don't have to be an employee, right? Small businesses, you can actually offer real health solutions for you, yourself, your family, and your employees, right? At a cost that's reasonable.
Correct.
Right? And then
I'd love to see that. I'd love to be able to walk into an employer's office and say, look, we're going to manage your care, your employees' care, a lot easier, a lot less cost, for everyone in general, and have healthier employees.
And I think that's a reality, right? That is a reality. Like, we have the pieces here, right? We have residency programs here. We are graduating family medicine residents every year, right? Just to be sucked up into these systems, right?
Imagine let's take it back 75 years when you had doctors. You usually had one doctor or a few doctors in your town.
Yep.
And they knew you front to back. They knew who you were, your health. They knew everything about you. They knew, and it's funny to say because as I was raising a family, we had one doctor that we saw, and that doctor took care of all of us, my children as well as my husband and myself. He knew the entire family. He knew all about us. He knew what was happening with my kids. That doctor was amazing. And he was 80 years old. He was still practicing medicine at 80 years old.
Yeah, that's how it used to be.
That's how it used to be.
Like I came up on the cusp of like what medicine used to be and what it's become. And so when I decided that I wanted to be a doctor, it was because I still saw remnants of what medicine used to be, right? That family physician who knew you, who actually cared about you, wasn't rushed out, it wasn't this managed care system where they really, your number, it's about codes. It's not really about, again, they were still writing in charts,
Correct.
illegible as they may be, but they were still writing in the charts, right? They weren't impressed by time. None of some of them like took too much time, but medicine used to be that. I think DPCs in particular, because again, like the defining difference between direct primary care and concierge is that we do not bill insurance, right? It's a philosophical stance that we take, that we do not bill insurance because again, we do not want to contribute to the healthcare crisis, right? When we know that it doesn't take that much to care for someone, right?
Let me ask you a quick question. What do you think, how do you feel AI is going to impact you taking care of someone? I just did a visit with my sister where the physician used an AI tool to determine what kind of care she needed.
I'm gonna say it probably did better than that physician.
I was concerned about it because although he used the tool and he was using ChatGPT, okay, and he recorded the entire visit.
Yes.
And it was like, okay, I get it. You're recording it. And he was showing my sister basically everything that she said. ChatGPT looked at it and said, recommendations. Now, I mean, is the physician now just solely going on what ChatGPT is recommending? Is that their findings or how are they?
So here's what I will say
I wasn't too keen on the whole idea.
I use AI for scribing, right? Because it gets me through my day much faster because now I can sit and I can actually have a conversation with my patients. Like my appointments can be 3 hours, right? And it captures that whole conversation and it can like summarize the conversation. But I'm driving the conversation, right? The patient's driving the conversation. I'm making the recommendations. It's just scribing for me, right? So that my note is pretty much complete when I go back through it, right? It's like I've talked to them about their plan that I came up with. Like, it's done this. But what I would say is that AI, especially in busy practices, can be much more beneficial than the physician sitting there, right? And when you're seeing 20 to 30 people a day, first of all, it's only as good as the input that it gets, and that's gonna suck because you got 7 minutes, right? So it's gonna suck anyway because you don't have enough information that you've been able to give it. And so its recommendations are gonna be based on the information that was put in there, which again, most of the times I think it's probably gonna be a little bit better than the person sitting there. Right? And ultimately, they're probably still going to not be able to do half the stuff that's recommended. They're going to send them out. That's just what it's come down to. But I think in those settings, it's mainly about now providers, can you see 30 people now? Because you don't have to scribe your note anymore.
Right.
Right. That was the biggest complaint. How do I get these notes done? Like it's done it for you. Now you can see 30, 40 people a day. That's what it's going to do to insurance-based care. It's not going to get us better outcomes because it doesn't have enough information. Garbage in is garbage out. Right? So 7 minutes with that doctor, an hour with me.
What I saw him do was basically just verify everything that that the ChatGPT inscribed, what it documented, and then what it recommended was the same thing that he would recommend. So he was kind of more or less just checking on, okay, this is what this AI tool is saying that you should be taking. We've gone over your medication. You are currently taking those.
What though, right? The input is going to be poor because you don't have time to actually do a well-rounded, like, again, and then over time, like that's the great part, right? If it's trained so that like this patient, it remembers its information and it can, so it can synthesize that information a lot better than a physician. The problem is that physicians don't go back and look at charts. They don't go back and look through records. They don't go back and look at trends for labs. They don't do any of that. So if AI is able to synthesize all of that back data and all those data points and then put things together and now make a recommendation that they couldn't have been able to make in that 7 minutes because they can't go back and look at all of that data to pull it forward. I can see how we won't be missing as many cancers as I caught when I was at my last employer, right? Because no one went back and looked at labs. No one saw that this man had a PSA of 70 something 5 years ago. It just got lost because of all the turnover. Because now if AI is in control in these situations, right? It doesn't really matter anymore, the turnover. I'm assuming, again, I don't know how those systems are working, but if it can track that same patient visit after visit after visit, right? If it can track the labs, if it can track the imaging, that physician isn't going to go back and look at because they don't have time. It's going to be helpful in that way. Okay. And I think that's good for the general public. So I don't think it's a bad thing because the person sitting there can't do it. Right? But again, I'll go back to say, if it's done that way, if it can be done that way, I think we'll have better care than what we have now. So yeah, I'm all in on tech. I'm all in on tech done the right way because it can help us be better. And I think if in that instance, it could help them be better because what we have right now sucks. It sucks. So yeah, that's the only thing I would say is, like, again, a 7-minute visit doesn't give you enough information.
Correct.
Right? So
tell me what's hurting you right now. That's it.
AI can't do anything with that. Right? And so having a bunch of those 7-minute visits, you know, and again, if most of that is used to then just deal with the things that the check mark boxes we have to mark for insurance purposes, right? We got to make sure that these things are said and covered and done just for insurance purposes. We already know that really isn't getting us where we need to go. But if it at minimum helps them do some of the bare minimum stuff that they're maybe forgetting to do because they're rushing from patient to patient, they're trying to close a note, they're trying to like send off, you know, lab orders or whatever, referrals. I think it can only be beneficial. I don't really see what the additional harm could be when we're already in a bad situation.
Okay.
I think it's just one of those things of like, again, for me, I'm like, you know, we don't get a good rap anymore anyway. So I would prefer to see AI in those situations. It doesn't replace real medicine, but you're not getting real medicine in those situations either. Right? So it doesn't replace like the holistic care that I can give someone. It doesn't replace, right? It's going to give you textbook answers, and people aren't textbook.
Right.
Right. And that's why we say it can pass the MCAT. So I know how smart it can be. It can pass the MCAT, but the MCAT is not real life. Right. So the recommendations are going to be sound, but they're going to be based on insurance-based care, right? It's not going to be, well, what other supplements can I take? Like I had a UTI the other day, and they're like, I don't want to take medicines. I said, fine, take berberine, right? You don't have to, right? If that's what you choose not to. Now, you're going to have to take it much longer than you would have to take this 3 days of Cipro, but you don't want to take medicine. There are ways of being able to do that. In an insurance-based setting, right? I would be less likely to say that. One, I wouldn't even known it was an option, right? And so like, I didn't have time to look at supplements, herbs, peptides, exosomes. I didn't have time to study that stuff because it wasn't part of my prescriptive habits, right? Because it's not insurance-based. Now that I'm not in that world, like I can do the whole person, right? We can talk supplements, we can talk peptides, like we can talk exosomes, we can talk medications, but we can have that whole conversation, right? And not box you in. And again, ideally get you to the point where you don't have to be on medicines, right? Medicines are Band-Aids. They're not fixing you.
No.
Right? So let's talk about how we fix you. Because again, I was alluding to earlier, when I went to medical school, I thought I came out learning prevention. And my thought was, because you taught me how a disease started, that inherently taught me how to make it better, right?
Prevent it. You know how it started.
I realized I'm the only person that thought like that. I'm like, that's not what they taught us. Like, that's what our basic sciences were about. Like, you taught us how diseases, you know, got there, how they started. That to me tells me then I should now have a plan of like how to prevent it. Yeah, I learned like I was the only one that saw med school that way. Like, I'm like, oh, we don't prevent things? I thought we did. So again, like I've always been about like, how do I prevent things? How do I make things better, right? And I think that's the thing AI will never replace, right? AI can be an assistant, right? But it can't replace it. I correct AI quite often, right? It just hasn't gotten good enough to be able to replace thinking physicians. But it does. Look, I'm not mad at that situation at all. I'm not mad at that situation at all. I'm like, yes, take AI over whoever is sitting there.
Okay.
So I'm like, so thank you for sitting down and talking to me. Like this has been enlightening for me. Hopefully the audience as well. I've learned some things. And so we're going to end our segment here and we're going to go to unmasking questions that I've gotten from the audience. And so one of the questions I got was, if you sneeze too much, is that an indication that you're sick? Interesting. So I say that no, typically sneezing too much is usually an indication that your sinuses have been overactivated in some way, right? So sneezing is really your body's way of cleansing the air that you filter. And so again, sneezing too much does not indicate that you're ill. It does indicate that your sinuses are offended in some way.
Something like allergies? Could be an allergy.
I like to, when I say allergies, people think it's like I'm allergic to something, right? And being allergic to something is very different than having like seasonal allergies or what we call allergic rhinitis. And so it really is whatever's in the air is offending your face in some way, right? And so it's making those hair cells, capture whatever particles. It's making your sinus cells secrete more mucus, right? It has activated this histamine chain again, and then plus the hair cell trappings is really what's happening with the sneezing. That you now are trying to expel it. It's really your body trying to cleanse itself from whatever it's trapped on those hair cells or whatever's tickling your nose from filtering. So it could be, the fires. It could be the wind, right? And now you have all these different dust particles and what have you in the air. It could be almost anything, and everybody's going to be a little bit more sensitive to something. So it doesn't necessarily mean that, it's an allergy. It can be, but typically I just like to say, like, your face is like offended, like your sinuses are offended, and you're gonna, try to cleanse it out by sneezing it, right? Which is why sinus rinses, like if that's happening, like just rinsing your nose with like nasal saline helps your body clear things, right? So that was one question. So sneezing doesn't mean you're sick.
Just means your face has been offended.
Your face is offended and you need to figure out how to fix it, right? Okay. It doesn't mean that something's still wrong, like you shouldn't be sneezing, but it doesn't necessarily mean that you're going to be running a fever or that you're contagious or anything like that. And the other one was like, okay, we live in the desert. How do we know if we're hydrated well enough?
I think it's just the fact that I'm not thirsty. If I'm hydrated, I'm not thirsty. I kind of figure I'm not thirsty.
And so like that's not true either, but that's close. I think some people think like if your desire for thirst or water, that should be some indication, or some people think it's skin or nails or what have you. But the reality of it is, if your urine is actually clear, you're well hydrated, right? And then if your urine is clear, you're typically gonna see like the improvements in skin and saliva and things like that. You won't have like a dry, tacky mouth. There are some indications that say like you don't have enough hydration for sure. But like the best, easiest way to say, am I well hydrated is like, does my urine look like water, right? That may be overhydration. There should be some color to it, but like, is it clear versus like dark? So that's like the best indication for hydration. And that ends our unmasked questions for the evening. Our lovely guest, Silvia, for...
Thank you again for your invitation.
Absolutely.
I love learning more about health. I love the fact that you're promoting primary care.
Yes, like whole wellness, DPC specifically. And I do think there's a future for this blend, I think will help everyone involved. So thank you. So don't forget to follow us at IsomMD on all the socials. It's actually Isom_MD on all socials, and continue to follow us and subscribe to our YouTube channel at Isom_MD. We are looking forward to bringing you more unmasked medicine. Medicine Unmasked.